Good morning, everyone. Dr. Christine Smith back for a wonderful interview for you today with Dr. Ellie Campbell, who is an osteopath and board certified in family medicine for over 30 years and also board certified in integrative medicine. So I wanted to invite her and really understanding cardiovascular health, especially how it's tied to the oral connection, which I think is often overlooked. And so we wanted to come on and talk about this today. Hello, Dr. Campbell. How are you?
Hi, Dr. Christine. It's lovely to see you this morning. It's morning.
Lovely to see you too. I was just telling everyone a little bit about you, but why don't you tell us a little bit about yourself and how you came to fall in love with this niche of cardiovascular health and family medicine? And I know you've written a book on things, so I want to tell people about that. Fantastic. And then tell everyone the title of that really quick so they can see it one more time.
Yes, absolutely. I will. Hi, everybody. I'm Dr. Ellie Campbell. I'm a board certified family physician and have been for over 35 years. For 13 years, I practiced real conventional family medicine. So that's, a pill for every ill and a drug for every bug. And it was not very satisfying. I followed the best evidence-based medicine in the country with the experts telling me what to do. And all I did was write more prescriptions and watch my patients get fatter and more diabetic and more depressed and more bipolar. And part of that is environmental. Our environment got worse over time. But part of it was the paradigm. The paradigm was wrong. And so I went to a conventional, an integrative medicine conference that shook my world and went back to the idea of root cause resolution. Go back to your pharmacology, to your physiology books, not your pharmacology books. Go back to anatomy and physiology and look at how the body is made and how we're supposed to work. And when we start paying no attention there, then we could get to the root cause, take away the interferences that are causing people not to be healthy, give them what they need to be healthy, and miraculous things happen to their health. So after 13 years practicing that way, I left. I left my very comfortable practice and started my own solo practice where I could set my own rules. And that was wonderful. And things were going great. And I sort of niched into bioidentical hormone replacement therapy because that seemed to be an unmet need in my community. And when you start doing hormones, then you start to learn about thyroid, and then you learn about adrenals, and then you learn about gut, and then you learn about toxins, and pretty soon you're a full-fledged functional medicine doctor. So I was practicing full-fledged functional medicine, and a patient came into my practice who was 43 years old and wanted to have a baby, a second baby. She'd already had one, and she was having terrible fertility issues. And they told her that her and her husband's genes didn't mix, and they would never have a compatible baby. And she said, well, that doesn't make sense to me because we already did it once and didn't seem to be a problem. So I helped her successfully get pregnant. And she had a beautiful baby boy. And so that was beautiful at age 43 that she became a mom again. And she said, maybe you need to see my mom because my mom has hormone troubles too. So I started seeing her mom. Her mom was Dee. She became one of my very favorite patients. She was a super spunky grandmother. She rode four-wheelers with her grandkids. She was a line dancer and loved to go out partying with her very much younger boyfriend. And she needed some bioidentical hormones to be able to keep up and do all that. So she had hypertension. We took care of that. She had high cholesterol. We took care of that. And then a tragedy happened. And her daughter called me and said, Mom didn't come into work today. And I ran over to her house, frantically looked in every window, every door, couldn't find her. Finally found her peeking through the windows, had to break down a door to get to her. She'd collapsed. She was on the floor next to her computer. She'd had a massive stroke. She was paralyzed on one side. They called 911 and she went right to the stroke center. And I felt horrible, like I had done something wrong. I was her primary care doctor. She entrusted me to prevent her from having a stroke, and it didn't work. What was wrong with my best evidence-based medicine and paradigm that I was following? In addition to blending the functional medicine things with detoxification and lifestyle strategies and all those things that we were doing, she had a stroke anyhow, and I felt terrible. Well, she joked that it was going to take a long time in rehab to get that leg working because you can't really line dance with a useless leg. So she went over to the stroke rehab center and she was doing pretty well. But around day 8, I think, after her stroke, the unimaginable tragedy happened, which is that injured brain area that had been damaged by the stroke burst. and she had a brain hemorrhage, and Dee passed away. And I felt like somebody had punched me in the gut because she was so vibrant and so young for her age, and yet she had this tragedy. So I spent the next 3 years studying everything that I could to learn about cardiovascular and cerebrovascular disease and what could we do to prevent it. Because here we are on Valentine's Day celebrating hearts, and yet heart health remains the #1 killer in our country. Cardiovascular disease kills 1 out of 3 American women. And that's what Dee died from. And so, we worry about our breasts all year long, and especially during Breast Health Month. But 1 in 31 women die of breast cancer. 1 in 3 die of cardiovascular death. So 10 times more women are affected by their heart. So I felt as a primary care doctor that really needed to become a significant portion of my practice is helping people prevent that tragedy. In taking that deep dive, I learned the secret and I learned what happened to Dee. And I now know that heart attacks are optional, strokes are stoppable, and dialysis is not your destiny. All 3 conditions are connected, and all 3 conditions can be prevented and even reversed if you get the right tests and you're willing to do the work.
Wow. Thank you for sharing that story. I think there's nothing more powerful for practitioners than when you encounter a situation like that. It just changes your passion and makes you dive deeper into things than you ever have before. So I'm so glad that you've done that. And that's it's really challenging because I think a lot of people have these amazing people in their lives who are younger than their years and then run into some kind of health condition that suddenly ages them a decade overnight. And I have like a list of questions that I'd love to ask you, but one of the things that popped into my mind that I think is just really important for people to know, and I think you'd be a great person to ask, is I know heart attack symptoms can vary between men and women. So really quickly, just so people know, what does it feel like if you're having a cardiovascular episode coming on for men? And what does it feel like for women? Just so people can identify it and get help sooner than later. And then we'll dive into the rest of the
Yeah,
questions.
this is so important because in part women have smaller arteries in general than men. And so when we have an event, it's usually not as large and can be overlooked. That means that our current level of testing misses many women. And up to 30% of women with a clean cardiovascular workup will go on to have a heart attack in the next few years. And they feel like it jumped out of the bushes. And how did this possibly happen? I had clean arteries. They gave me a clean bill of health. And it's because we're asking the wrong questions, we're using the wrong tests, and we're not, as practitioners, tuned in to the nuanced differences of how we present. So how does a man present when he has a heart attack? It's usually drama, right? It's, oh my gosh, he grabs his chest. He holds it over his hands over his heart, and he says, my arm is throbbing, my left arm is terrible. And then he breaks out in a cold sweat, and then he gets queasy and he turns a little bit green around the gills. He might even throw up in his shoes. He's breaking out in this cold sweat and he's grabbing his chest, and it's very dramatic, and everybody knows, oh my God, he's having a heart attack, call 911. And they get him to the hospital. When a woman has a heart attack, she says, I don't feel right. I have a little pressure, sort of, in my chest, kind of.
When they can get some jaw pain too, right?
My pinky hurts,
Mm.
or my jaw hurts, or the tip of my shoulder hurts. Just a little. It's not really pain, it's more discomfort. And I'm winded. I used to be able to vacuum this whole room, and now I can only vacuum 5 seconds and I have to rest. I feel winded. And maybe a little heartburn or indigestion. And those symptoms can be a freaking heart attack in a woman. My sister-in-law was an emergency room nurse, and she took care of people coming in. And she said that after years of experience and missing people who are having heart attacks, especially women, any woman over the age of 25 with any symptom that wasn't trauma above their waist, any symptom above their waist got a cardiac workup in addition to whatever else it was that they came in for. And part of what changed the policy of that emergency room was a woman who came in complaining of pain in her pinky. It was the only symptom that she had. She said, it's a very unusual discomfort. I've never had anything like this before. Nothing else hurt on her left arm, just her pinky. And they dismissed her and they put her to the bottom of the list and they put her on a gurney and they went back to check on her in an hour and she had died of a heart attack. And so it changed their paradigm. It changed how they do the workup now. So any woman with any, or man with a symptom above the waist gets a cardiac workup. And I don't think that every single woman needs to be running to the emergency room for every single symptom, because that's overcall as well. But if you know that you're at risk because you have high blood pressure, and we say high cholesterol, but it's really a certain type of cholesterol. It's not regular cholesterol, and many doctors aren't checking for it. If you have sleep apnea, if you're morbidly obese, if you don't exercise, if you eat Twinkies for breakfast, McDonald's for lunch, and pizza for dinner, and never get a vegetable in your diet, then those would put you at a higher risk for having an event. And especially, and this is the hidden secret, if you have bad oral health and you have a symptom, then that would be a reason to go be evaluated. And so I list those symptoms in my book. It's called The Blood Pressure Blueprint, The Holistic Guide to Defeating Hypertension. And I wrote that book so that people would have a guideline of what to look for and have a tool set of things to ask their doctors for, so that they know, besides their blood pressure, it's really a book about cardiovascular prevention. But I wrote it about blood pressure because that's something people can grab onto and understand pretty easily. Heart attacks often occur in people with hypertension, and only a third of hypertension patients are under control. So we really need to work harder to reduce that risk factor because we have control over that.
I absolutely agree with you. And I think these concepts are somewhat known, but I like that you dive into it more. And I love that you bring the oral health component in. And then I also love that you're a physiology nerd and guru, right? Like myself. So let's educate people a little bit just about how things like your kidneys are tied into your blood pressure, because you also mentioned dialysis. And I'd love to help people have that understanding.
Right. So when we think about hypertension, we're talking about elevated blood pressure. So I like to use the analogy of a garden hose. And if I have a garden hose that has a weak spot in it, and I'm very careful how I turn on the water at the spigot very slowly and just get a trickle going before I get a little more pressure to get enough water to water my garden, that weak spot may never manifest. But if I turn the water on really fast, that could be a problem. Or if I tie a knot in the end of the hose and then turn on the water, that's very likely to be a problem. So blood vessels become weak under pressure over time. And so the smaller the blood vessel, the more at risk it is. And as you can imagine, blood vessels get smaller as they get deeper and deeper into organs. So the tiniest blood vessels are found in our brains, in the back of our eyes, on the surface of our heart. And that's a little confusing because um, we know that we take a chicken and we see the heart, we know it's got big vessels that come out of it. Those aren't the ones where the heart attack happens. The heart attack happens on the little itty bitty tiny vessels that come out of there and go into the muscle of the heart. So they're surface vessels. They're not the ones that pump blood. Those are the ones that cause heart attacks. They're itty bitty ones. And those same itty bitty vessels are in our kidneys. So under the stress of chronic everyday hypertension, our kidneys begin to get choked. They don't get enough circulation to them, and they begin to make toxins that collect in our urine that or in our kidneys that damage them, and that can be released in the urine and measured. So we have urine tests that can help us determine if we're making markers of oxidative stress, if we don't have enough antioxidants in our diet, One of them, for example, is called F2 isoprostane. It's a test I do in my office every day, 3 times a year in most patients. Most primary care doctors don't check for F2 isoprostane in the urine to see if the patient has a leading indicator that tell us that their kidneys might be at risk. Once kidney damage has started, the blood vessels in the kidneys kind of swell up and they don't hold a tight seal. And when they swell up, now protein can leak from the blood and the serum into the urine. So I can now detect microscopic amounts of protein in the urine as a marker of kidney disease. Now, fun fact is insurance companies have known about this for 50 years. Because when you go to have an insurance physical, they make you give a urine specimen and they check your urine for protein. If you have protein in your urine as a high blood pressure patient, then they say, oh my gosh, you have blood vessel damage. Blood vessel damage in your kidneys probably means blood vessel damage in your heart, and blood vessel damage in your brain, and blood vessel damage in your eyes. And you're going to be a higher risk insurance patient. So we're going to rate you at a higher rate because you have protein in your urine. So patients can see protein in their urine in the latest, most advanced stages of kidney disease. They see this frothy foam in their urine that comes from protein. But we have a leading indicator called microalbumin, microscopic amounts of protein in the urine that we can detect. We don't do that in the office. That has to get sent to the lab for them to detect it. But if we see microalbumin elevations in women, we know 7.5 is a marker that you're already getting kidney blood vessel damage as a marker of cardiovascular risk. So we can fix that. How do we fix that? Well, we get your blood pressure under control. We stop smoking if that's a problem. We get you on more antioxidants if you need them. We lower the amount of animal protein that you're eating because that's a real stress for your kidneys. Might not have to be forever, might have to be forever, depends on your case. We make sure that you don't have high phosphorus because phosphorus is a really harsh molecule for your kidneys. And we can counterbalance that with a little bit of calcium, a little bit of bicarbonate. Sometimes we give people, we call it in our office, Tums and Hammer. We give them Tums calcium and Arm& Hammer baking soda, but really not at Arm & Hammer. We usually give it in a pill because it's way easier to swallow than that nasty tasting salty bicarbonate soda. But you can get it that way too. So we check and monitor calcium, microalbumin, phosphorus levels in our patients. And we have seen people in stage 3 kidney disease go back to normal. And my
Wow.
colleagues, I have some colleagues who are kidney coaches. They are nutritionists who coach kidney patients. They've taken 23 patients off dialysis that were so kidney damaged. They were going to the dialysis center 3 times a week for kidney dialysis, no longer need it. When we got their cardiovascular, cerebrovascular, renovascular inflammations under control. And so I just want people to know that you can be empowered to make changes. And even if you feel like you're sliding down the slope, we can climb back up and get off that slope. And it's not inevitable, but you have to work with a practitioner who knows what to do. And you have to be willing to do the work because especially in today's day and age of carnivore diets and keto diets, which make a lot of brains feel better, not everybody can handle that. Some people have significant kidney stress when they eat those diets, and they need to be monitored to be sure that it's safe as well as effective in your instance.
That was such an amazing explanation. Thank you. I think it's often missed how much kidneys and lungs and heart are actually all very much part of the same system, and they help monitor our blood pressure. And I know you had mentioned like what you test in the urine, but there's a number of other tests that you really like to do. And then I'd love to also talk about like common mistakes people make when they're taking their blood pressure so that they can understand it better. And then after that, I'll dive into like a little bit of an explanation around the kind of leakiness that she's talking about in the kidney, right? Because it's epithelial tissue, which is very much like our skin, which is very much like our blood vessels in our brain and our heart and our gut. So when we're starting to have this leakiness in epithelial tissue, it's not just usually in one area, it's usually kind of across a variety of organs. But let's go first to kind of measuring blood pressure and the other evaluations that you really like for people to do to
Yeah.
track this stuff.
So, kind of a secret about the book is that I wrote a book. It was, I think we called it something like Mouthology or something like that. And it was a book about the same stuff that's in my blood pressure blueprint book, but it was really boring and it was really techy and it was not interesting. And we pitched it to about, and it highly emphasized the oral systemic connections, the way that mouth bacteria can be one of the things that cause leakiness of your epithelial tissue. And endodontic bacteria, those that live in the tooth roots, those are real havoc players and they can cause strokes and heart attacks like they did for Dee. Um, when I did that deep dive, I pitched my book to 85 different publishers and nobody wanted it. So I went back to the drawing board and I went to Google and I went to Amazon. I said, what do people want to learn about in their health? And the top 10 searches for more than 10. And so when I discovered that we had this need for blood pressure, I totally rewrote the book and decided that I was going to become a blood pressure expert. I mean, I check blood pressure in my office every day and have for 35 years. Clearly, I'm an expert in blood pressure, like every other primary care doctor. But when I did that, I realized I'd been checking blood pressure wrong. I hadn't been following the 2017 CDC American Heart Association guidelines, and I was doing it wrong. And every single office that I've been to since I learned this is also checking my blood pressure wrong. So let's go back to fundamentals and tell us, what do the experts say? How do we measure our blood pressure? The first thing, the first trick is your bladder has to be empty. If your bladder is full, it can add 10 to 15 points of blood pressure elevation falsely to your blood pressure reading. When I go to the doctor for a checkup, I know they're going to need a urine specimen. I've drunk my full glass of water in the car on the way over, and I got to pee the minute I hit the door, but I know they're going to need a urine specimen. So I cross my legs and I wait until I get in the room and they check my vital signs. And then I say, do you need a urine specimen? Because I really have to go. Meanwhile, they've checked my blood pressure with my bladder full. And that elevation can last for 3 hours if you wait till your bladder is painfully full. So trick number one, empty your bladder before you check your blood pressure. That means at home as well as at the office. Tip number two, I happen to be vertically impaired. I'm only 5'1". And so the trick to measuring the proper blood pressure is you have to be seated in a chair with your bottom to the bottom, your back to the back supported, and your feet on the floor. I can't sit in 90% of chairs with my back to the back and my feet on the floor at the same time. My legs are too short. So in order for me to get my blood pressure properly measured, I need to be using a step stool underneath my feet to support them, because not letting your feet touch the floor or having your ankles crossed can add 5 to 10 measurement points on your blood pressure falsely, just because you're too short to put your feet on the floor. Or they measure you on the exam table with your legs dangling. That's an improper way to measure blood pressure, right? So there's 6 or 7 other things that we do. I don't know that we want to go through all of them, but I think those 2 are really big. Bottom to the bottom, back to the back, feet on the floor, empty your bladder. And that can add 10 to 15 points of false blood pressure elevation. We need to be measuring our blood pressures at home, not just in the doctor's office. There's a thing called white coat hypertension, and it's real. People measure their blood pressures at home, they're perfectly fine. They go to the doctor's office, and for whatever reason, that psychological stress, the fear, whatever it is, will raise their blood pressure, and it'll be much higher in the office than it is at home. Those people, generally speaking, do not need to be on blood pressure medicine. They have false white coat hypertension. Unless those same people get that same reaction when they have a fight with their spouse, when they drive in the car, when they watch a television show that's high stress or high action, and their blood pressure is going up at home all the time in the same way it is in the doctor's office, those people do have hypertension and do need to be treated. Not always with medication. Sometimes we can use supplements, lifestyle changes, weight loss, sleep apnea treatment, dental care, whatever, but they do need a treatment. There's also the opposite. Some people have, about 10 to 20% of people have something called masked hypertension. They are able to put themselves in a state of zen as they're getting out of the car before they go into their office, and they're able to manage somehow to get their blood pressure under control, but at home it's high. We miss those people, which is why it's so important that everybody has home blood pressure monitoring as part of their wellness strategies. We need to be looking at it in good situations. Let's like future son-in-laws, right? You want to see your future son-in-law on his best behavior, but you also want to see him on his worst crappy day. How does he treat your daughter when he's really having a bad day? You want to know the same about your blood pressure. What's it like on really good days? What's the best you can get it? What's the worst you can get it? Is it impacted by food or caffeine or sodium or stress or sleep? We want to know those variables because that helps us as practitioners be better able to treat and manage you without over treating you, because that's also a danger. If I give you too much medicine, your blood pressure is going to drop. You're going to be lightheaded and dizzy. You might even pass out. And that can be a terrible tragedy in a senior who has weak bones and falls and passes out and hurts something, breaks a hip or worse. So we don't want to overtreat either. And the only way I can know that is lots of data at home, plus my data in the office. I would never treat a diabetic and calculate their insulin dose based on a single blood sugar reading in my office. Why would I ever manage a hypertensive patient with a single reading in my office?
I love that you just shared all of those. I've known about the posture thing. The bladder one is new information, so I'm going to be making sure to apply that in my own practice. Thank you. And I know that you had mentioned, other ways that people can track these things, everything from neck ultrasounds to CT scans. Any other tips that you think are just important for people to know, I'd love for you to share. And then if you're open to it, I would also love to hear your opinion on things like blood pressure medication and when it's appropriate and when it's overused.
Right. Okay. So we'll talk first a little bit about other testing. So we're going to switch a little bit from managing hypertension to preventing cardiovascular disease, right? In the current paradigm, we say people are either primary prevention or secondary prevention. Primary prevention is people who have risks. They have high blood pressure, high cholesterol, obesity, inactivity, smoking, but they've never had an event. But I want to make sure that they don't. That's primary prevention. Secondary prevention is somebody who's already had a stroke or a heart attack, and we want to not let them have another one. I think that paradigm is broken because of something called the myth of mild disease. And the myth of mild disease states the following: 88% of strokes and heart attacks happen in people who have mild disease. 88%, because there's so many of them. So if you go to the emergency room because you had pain in your pinky, and they're very astute and they assessed that you were having a cardiac pain in your pinky, and they did this big workup and they took you to the cath lab and they ran that dye up your groin and into your heart, and they said, great news, you didn't have a heart attack and you only have mild disease. You can go about your way, go see your primary care doctor. Well, the myth of that is 88% of heart attacks happen in people with mild disease. This needs to be a full court press of an evaluation of how do we treat you. And I think that we should have primary prevention, people who've never had an event, secondary prevention for people who have disease but have never had an event, and then tertiary prevention should be those who've already had an event. And I think we should create a different paradigm with the second category, because it's 88% of people, right? The ones who have disease but never have had an event. And you can't look and tell, because I have triathletes who look for all the world to be healthy as a horse, and they have very advanced vessel disease, which I can reverse. And I have people that look like couch potatoes, who are overweight, who have bad health habits, and have no vessel disease. So, assuming that they haven't been to the emergency room to have a cardiac catheterization to see if they have plaque, what can I do outpatient to assess if they have plaque? And there's two really good tests. One is called a coronary artery calcium score. It's a CAT scan of your heart. It's generally done without insurance, and it generally costs between $99 and $150. It's the cheapest CAT scan on the block. And what they do is they take a super ultra fast a picture of your heart. And if those vessels that sit on the surface of your heart have calcium in them, they have advanced, old, mature plaque. It will miss some patients who have early onset mild plaque, but it will find advanced plaque. And put you on a graph and say you have more plaque than 77% of women your age, or you have more plaque than 30% of men your age. Any plaque is too much and needs to get a full court press of all these evaluations for inflammation, oxidative stress, insulin resistance, sleep apnea, oral health, all the things that we can do to reverse their disease. The other test is called a carotid intima media thickness measurement. The arteries of the carotid go into your brain. They get smaller and smaller and smaller, and they're very large. They're about the size of a pencil. You can find your carotid artery if you find your Adam's apple, slide about an inch over and feel your pulse. That's where the carotid artery is. That will start to form plaque. And guess what? It's very close to the base of the roots of your teeth. So if you have dental disease, that mouth bacteria can get in and start to make plaque in your carotids when it hasn't made any plaque in your heart. So I like to do both tests because some people live in fear of heart attacks and other people live in fear of strokes. And I can't always tell that from our conversation or even with the data. So I like to do both tests. If you go to Lifeline screening or one of the trailers that comes through and goes to your church and does a health screening, they may do a carotid ultrasound and they will be looking for plaque in the artery. But that's not what I want to see. The earliest marker, the leading indicator, the soonest that I can tell is, do you have plaque behind the drywall that hasn't formed a lump that makes plaque that we can measure as a disturbance in the blood flow? I'm looking to see, are you starting to form inflammation behind the drywall? Because 99% of that plaque forms behind the drywall before it makes a speed bump that we can detect in the artery wall. So this is a leading indicator that I can use. If I see people with advanced or above their age intima media thickness, it's an indicator to me that they are at risk. They should be in the second category of secondary prevention, people with plaque who haven't had an event. And now we start a full court press to look at all the leading indicators that we can and identify every contributing root cause and chip them away one at a time, visit after visit after visit. We just keep taking away those risk factors. And then what I see over time is reversal of the plaque. That was new to me. I thought once you had plaque, you always had plaque. It's not true. In my practice, 90% of our patients will see reversal of their plaque. 75th percentile year 1, 60% year 2, 50% year 3, 14% year 4. So we're seeing this reduction in the plaque and thereby a reduction in their risk.
The body is amazing. I think people forget like how many health conditions can reverse themselves if you provide it with the right support. And I think this actually leads beautifully into the conversation we were going to have about oral health and your gut health and how this affects your cardiovascular system. And it can kind of become like a chicken or the egg situation, but like what came first, but it's usually tied to some kind of disruption in your body's microbiome, whether that's in your mouth or in your gut, because they're not separate. It's the same channel, it's the same microbiome. So if you're struggling with a ton of cardiovascular health and you're having bacteria build up in the mouth and that's going into the blood vessels, because it's not, our tissues are permeable. It's not that these bacteria just go straight into your gut. They can move through the tissues and into our blood vessels and then produce inflammatory molecules. And even, genetics can kind of play a role too, because I think one of the cardiovascular markers that people don't often measure is homocysteine, which I use as a great marker for understanding if you're having inflammation and irritation in the cardiovascular system. And all of that can also tie into being affected by your gut biome. So let's go into that a little bit, because, you know, what I was mentioning earlier is like epithelial tissue is your skin, it's your cardiovascular system, it's your blood vessels, it's the lining of your gut. They're all the same tissue. So if there's a disruption in that tissue from things like dysbiosis or unhappy bacteria in the gut that are producing molecules that are essentially inflammatory and causing your immune system to overreact in the area, which can end up accidentally damaging tissues while trying to protect you. This is how this can kind of start to cascade over time. So I'd love to hear your expertise around this and just what you really want people to know and how you see it starting in your practice and where they can catch it early and how you like to address it.
Right. So everything you just said about the gut also happens in the gums, right? So they're epithelial tissue too. They have a microbiome too. They can get abnormal bacteria, viruses, and fungus there in the gums. That can lead to inflammation. That disturbs the epithelial barrier. And one simple way to know is, do you have pink in the sink? If you brush or floss and you spit in the sink, is there any blood? There should never, ever be blood. Unless, okay, you just ate popcorn, you got a big thing of popcorn stuck in your gum and you had to dig it out. Okay, in that case, there can be blood. Um, I had pink in the sink last week and it scared the crap out of me. And then I remembered I'd just eaten a strawberry macaroon. So that doesn't count either. So, but nevertheless, pink in the sink most of the time is a marker of gum inflammation. And just like in your gut, gut inflammation can run the gamut from very mild and easily reversible to very severe and permanent damage. And so we have words for that in dentistry. They call it gingivitis when it's very early, temporary, and reversible. And they call it periodontal disease when it's, we used to think periodontal disease, like cardiovascular plaque, was permanent and never reversible. We know now that's not true. It's never reversible if you don't treat the root causes. If you don't get rid of the yeast, the abnormal bacteria, the lifestyle changes, the bad mouth pH, the bad diet, the oxidative stressors, if you don't fix those, you're never going to fix periodontal disease. But we can, and we can even to some degree regenerate some of that gum tissue that people have lost. Now, if the periodontal disease is so severe that you've lost teeth and you've had teeth wiggle and fall out, that's irreversible. That's the worst case scenario. Almost all those people knew they had a problem before their tooth fell out and they didn't get it fixed, or they didn't know how to fix it, or their practitioner wasn't educated enough to help them understand how to fix it. So this is where, as a consumer of healthcare, I want to ask my dentist the right questions. I want to ask my dentist, do you have experience in biological or holistic dentistry? Do you know how to reverse periodontal disease? Can you measure my mouth bacteria, my mouth fungus, my mouth virus? Do you know what's living in there that we might need to treat? Because some of the most resistant cases of periodontal disease have a fungus, a candida that's living there. And they don't have thrush, they don't have visible states of fungus, but in that microbiome, in that biofilm, trapped in the goo that's in that stinky floss between your teeth, is a colony that's multi organism. It's got yeast and virus and bacteria, and they're all having crosstalk, and all those guys are talking to each other. And this guy over here says, I can make half of a protein, and this guy says, I can make half of a protein, and together we can make a whole protein that can act like a cocoon to cloak us and protect us and hide us from this person's immune system. And then we can grow and develop and make inflammation, because when we do, we get blood in this pocket, and we love blood. Blood is one of our favorite fuels of our bacteria. And so Porphyromonas gingivalis, for example, one of those mouth bacteria, eats blood as a favorite fuel. And so the more bloody the mouth, the more happy the PG is. And then it has this nasty habit as it buries itself inside a red blood cell. So now that red blood cell, when it leaves your mouth and goes back into your circulation, can travel anywhere in your body. And that Porphyromonas gingivalis red blood cell that's infected can travel to your brain or to your kidney or to your heart. And when it does, it's this bacteria, Porphyromonas gingivalis, secretes a thing called phosphorylated dihydroceramide. It's wax, it's plaque. This stupid bacteria makes its own plaque wherever it lives. So not only has it made plaque in your gums that you see as plaque on your teeth, it makes plaque in your arteries, in your brain. That can be Alzheimer's. That can be cardiovascular disease, that could be stroke, that could be heart attack, all because this little mouth bacteria left your mouth and hitchhiked on the red blood vessels everywhere else in your body. So we want to be sure that we can get rid of the bad bacteria without destroying the good bacteria, right? Where our mouth is supposed to be teeming with bacteria. We need them there. They make enzymes. For example, there's one called nitric oxide synthase. It's the rate limiting step in making nitric oxide that keeps our blood pressure normal. If we use napalm and annihilate all of the bacteria, or rinse with bleach that's too strong, or Listerine, and we try to kill all those bacteria in our mouth, we kill the good guys too. And it'll raise our blood pressure, and it's not good for us. So we have to be gentle and careful and work with our dentist to be sure that we get the right kind of mouth care. And often that will include specific dental probiotics. Just like we use specific gut probiotics. Sometimes we need lactobacillus, sometimes we need bifidobacteria, sometimes we need a spore former, sometimes we need all three. It depends on your case. You don't want to self-prescribe. You want to work with an educated practitioner. And the same is true for your mouth flora. And we now have spit tests that can help us identify, do you have the ugliest mouth bacteria that we know are associated not only with cardiovascular, with periodontal disease, but also cardiovascular disease, stroke, diabetes, cancer, pregnancy loss from mouth bacteria, because they're so inflammatory, they can even go to the uterus and upset the balance of inflammation in the uterus, cause it to be over twitchy and lead to a miscarriage. So we want to get those mouth bacteria under as good control as possible before the second trimester, ideally, because it's better for the mom, better for the baby to treat early. And then often probiotics are part of that. And there's a few mouth bacteria that probiotics that have been specifically studied that really can shift the needle and help those crowd away, make an uninhabitable environment for the bad bacteria to live there.
Wow. Okay. I hope you guys just heard everything that she said. This will be recorded so you can go back and watch it again. But she just tied together why things like your oral health and your diet are completely connected to not only cardiovascular disease, but also later in life, your brain health. Things like cognitive decline, which is becoming rampant in our society, and also how it can even be tied to a miscarriage and your ability to be fertile and have a child. So all of these things are connected, and this is the idea of functional medicine, is it's systems medicine. It's understanding how they all interact through physiology and how to really work with them. So that was an amazing explanation. Thank you. And for anyone who's not familiar, biological dentist is different than your average dentist. They've usually had some more extensive training or studied functional medicine a bit. They use different testing. If you are considering, having some fillings removed or replaced because there's an infection growing underneath them, or their mercury, which generally is also not good for us. And at some point it can be good to have that taken out of our mouth. So we're not consuming it all the time. A biological dentist is going to do that in a very different way, using a lot of special equipment for it. And it does need to be done correctly. So working with these people can be huge. And I had a couple questions come in, and one of them was people asking if you ever work with people remotely, because I think the work you do is vastly needed. So wanted to let you tell people how you approach that.
Yeah, so in Georgia, I am not allowed to see patients remote unless they've established a relationship with me in person. So I do see people that live all over the world, but they have to come to see me in Georgia at least one time. That initial appointment is at least 2 hours long. So they're here a long time. We get to know each other really well. And I operate only under a membership basis. So people who come to see me have to come see me for a minimum of 6 months, because I can't fix these things in a day or a week. It's a process.
Yeah.
At least a 6-month process, and sometimes longer. And so my practice is called Campbell Family Medicine. We're at campbellfamilymedicine.com. We have a Facebook page. And I'm not particularly otherwise social media very savvy. So this is my very first ever Instagram live. Yay!
Thank you.
So yeah, I do see patients remotely, but they have to establish first here.
Great. Yes, I think that's a pretty regular practice. I kind of do the same thing. So thank you guys so much for listening. If you have any other questions, drop them in the chat. But I just kind of wanted to start to wind down here. And if you were going to tell people something that you wanted them to know more than anything around their health and just what you think is the biggest hurdle people encounter, or just anything else you want to share with people, what would that be?
I would say that probably in terms of drugs, blood pressure medication is both overused and underused, and cholesterol medicines, including statins, are overused and underused, right? We should never treat a patient with statins based on their HDL or LDL alone. We should only treat patients with statins if they have the wrong kind of cholesterol. It's corrupted because it's sugar coated, it's oxidized, or it's the wrong shape or size, and they have vessel disease. If they only have a risk and no vessel disease, now is not the time to use statins. We have lots of other things to use. But if they have vessel disease, we use statins for their pleiotropic effects, which means that they lower inflammation, they lower oxidative stress, they stabilize the plaque, they increase the amount of calcium that goes in there to stabilize it to prevent a plaque rupture. And we can take them off over time once we've reversed their plaque and settled things down. But we use it as a bridge to get to a better, safer, healthier status. Bale-Donine is where I learned this from, the Bale-Donine method, and practitioners are all over the country. So I'm not the only one. In your community, there's likely a Bale-Donine practitioner who can help you. But you gotta get the understanding of atherosclerotic vessel disease as being the precursor to all these other conditions. That means plaque is forming, and plaque is a mixture of corrupted cholesterol, white blood cells, protein, inflammatory cytokines. It's a goo of inflammatory mess that collects in the artery, but it can be reversed with lifestyle. The path you're on is not the path you're stuck with. Heart attacks are optional, strokes are stoppable, and dialysis is not your destiny if you get the right tests and are willing to do the work.
Yep, absolutely. And if anyone wanted to check out your book, can you hold it up one more time?
Yes, it's the Blood Pressure Blueprint. It's available on Amazon, and ebook and paperback.
Excellent. So anyone, if you're looking for a good place to start, that'd be a wonderful place to start. Feel free to reach out to Dr. Ellie or myself with any questions. Our information is located on our Instagram. You can just go there and find out the best place to message. And also, this will be posted. If you have additional questions, comment below, because we do this for you guys. We want you to be empowered around your health and understand how your body works. And we can always do another one and kind of address some more advanced concepts. But if anyone wanted to find you, work with you, where would you direct them?
CampbellFamilyMedicine.com.
Perfect. Thank you so much for making the time to do this today. I think this is a really important topic and something that's not talked about enough. And so I'll be sharing this with a bunch of people to really work on their heart health. So thank you, Dr. Ellie, and I hope you have a wonderful rest of your day. And anyone watching, thank you for joining.
So welcome.
Okay, talk to you soon.
Yes, ma'am. Bye now.